If I didn't have a chance to meet y'all in Expo or in faculty meetings or anything like that, I am Miss Blackstock. I teach primarily in second semester in the day, but then I also do third semester too. So y'all should see me some this summer as well. So just a little bit. And I usually am not in scrubs, but I did just come from clinical, so. Also bear with me if my brain craps out on us about halfway through. Probably from not having a stroke. I've just used a lot of brain power already. So, alright, let's talk a little bit about mobility. So everybody, does it pull up for y'all okay? Okay. So what do we know are some things that mobility can do for us?
Makes us move. Get your balance, get mobile.
Okay, it can help with your balance. What else?
Skin integrity.
Skin integrity, yeah, it can promote good skin integrity.
And boost energy.
It can. Good look at you already reading. You're already catching on. You can just read what's behind me, right? Not that difficult. I try not to make it tricky. So if we think about too, we can, we get serotonin boost too when we move, right? If you're kind of feeling a little bit down, sometimes just getting up, moving, getting some sunshine, walking around, that sort of thing. But then we also know that it just promotes general physical fitness, okay? This should all be a review. None of this part should be any new information, okay? But then when we move on the other side of the spectrum, what do we know that the lack of mobility can do? Can it harm us?
Absolutely.
Yeah, in what ways?
You don't move, you don't use it, you lose it. Pretty much.
Yeah, you don't move it, you lose it.
Decrease muscle strain.
Yep. What, did you say something, or was that her?
I said muscle deterioration.
Yeah, muscle deterioration, kind of that atrophy, right?
And then
Kind of the flip
decline.
side of the skin integrity, right? We could have some pressure ulcers, things of that nature. Maybe we could even get into some more difficult things like pneumonia, things like that. But then also we know that immobility could be good, right? Because there's sometimes where it's not appropriate for us to get up and go stomping around everywhere, right? So we have to find that balance between mobility and immobility that gets us the desired effect. This just also review, we're not really gonna talk about it, it's just walking you back through things that you would wanna reflect on, to kind of prepare, not necessarily more for meat, but more for like HESI, NCLEX, that sort of thing. They can kind of revert back to, what do you need to know about kind of the cycle of life, essentially, okay?
It starts and then you get back there.
That's right. It is a true circle. Okay, so then this picture right here is just a quick reminder again about our anatomy. Everybody should have had at least anatomy 1 by now. So how many cervical spines do we have?
7.
Okay, and how many thoracic?
12.
12, and how many lumbar? 5. And then we get down here to our sacrum and coccyx, okay? You don't have to know every little piece of the anatomy here, but understanding the fact that there's a difference between the way that our cervical spine are formed, and then our thoracic, and then our lumbar, they look a little bit different, right? Okay. So when we talk about what else is composed in our spine, what else are we looking at? We have our actual vertebra that we just kind of talked about, and then what else do you know is in there?
Spinal cord.
Yep, our spinal cord, which we know that is protected by the vertebra, and what else?
Nerves. Muscle.
Well, our muscles aren't necessarily our actual spinal column, right? Discs, that's the big thing. We're gonna talk about disc injuries, okay? So that's gonna be kind of one of the first things that we'll talk about. Then, when we get into some of the other disorders that you may have, and we'll kind of, these will pop up a couple of times, but if y'all have ever heard of kyphosis, have y'all ever heard of that?
Yep.
Okay, and lordosis, scoliosis, we're gonna touch on those a little bit. So these are kind of gonna be the big spinal column disorders that we're gonna talk about. Mainly the disc herniation and then the curvature disorders, all right? So when we look at a disc injury, there's a couple of different things that can happen, but what do we think are some reasons that you could have a disc injury?
Lifting.
Lifting, absolutely. So what would maybe put somebody at a higher risk of having a disc injury due to lifting?
Jobs.
Jobs, yeah, manual labor jobs would be a big one. What about even just recreational activities, right? If they're a weightlifter, that would probably be one, okay? Especially if they're not using proper body mechanics. What else do we think could put somebody at a higher risk of having some sort of disc injury? What'd you say?
Nutrition.
Maybe, yeah. What do you mean by nutrition?
I mean, if they are, lacking nutrition or,
Okay.
have muscle weakness and they still try to do it.
Okay. So body habitus could be a big one too, right? We know, right, that if we carry more weight on our body, what is that gonna do to our bones, muscles, ligaments, tendons, all the different things?
Wear them
It's gonna put stress on them, right? It's gonna wear them out. It could put us at a higher risk for developing some of these issues. What do we know is really important about our core muscles? What are they helping us do?
Stand upright.
Yeah, absolutely, right? So our bones, our entire skeleton keeps us to where we could actually hold a shape, right? Because if we didn't have skeleton, then we would just be like jelly on the floor, okay? But you also have to support that because are we just standing in one position, like a statue, to where our bones and our skeleton can just hold us right there? No, we're moving around. So what's gonna make us have the ability to move around and support the movement of those bones and not just topple over?
Muscles, ligaments.
Muscles, ligaments, all that. So if I'm lacking some of that core strength and I'm not able to move, then I'm not gonna use proper body mechanics. I'm gonna be at a higher risk of developing some of those issues, right? Do you have a question?
There's also disc or degenerative disease.
Absolutely. Yeah, we'll talk very, very lightly about degenerative discs, but more so we talk about like inflicted injuries. All right, so if someone were to have a disc injury, we look at the assessment of that. If, let's say they had a cervical disc injury, then even without looking at that, what would you anticipate some of the symptoms they would have associated with? Absolutely, where?
In the arms, the lower half of the body.
Or maybe
A lot
not
of
even,
the injury.
yeah, I would say probably more of like my upper half of the body, right? Because if you ever wanted to look at a picture, like a diagram of where all the nerves are connected to our spine and where they go, it makes sense, right? Our cervical spine, what's closest in proximity to that? My hands or my feet? My hands, so it makes sense, right? If I have an injury here, then I'm gonna start feeling some of those effects more at my hands than I would at my feet. Where would the injury be if I did start to feel some of this in my lower extremities?
Lumbar usually.
Yeah, I'm thinking more of lumbar, even some in the thoracic as well. Thoracic is kind of this like weird space where it can do some funky things depending on symptoms. You can actually also have a lot of issues with some of like your organ function when you have thoracic injuries, because a lot of those nerves are connected there. So just understanding the orientation of where you would start seeing some discomfort, pain, and symptoms from these patients. And then we're gonna talk about treatment here in just a second, but obviously we have just a quick little synopsis there. If we suspect that a patient has a disc injury, what are some of the diagnostic tools that we think we could probably use?
CT, MRI, X-ray.
Yeah, I was gonna say, even before we get to CT, MRI, we could do an X-ray, right? It's quick, it's, you know, it's a small amount of radiation that we're exposing you to. We can see a lot on it. But what's an X-ray gonna show us? We'll talk a lot about X-rays today. A what?
Bone density.
Yeah, it's basically just gonna show us the structure, right? It's looking at the bones. It does what it needs. It's a great tool, but it doesn't go all in. You have a question?
I'm sorry, going back to, for specific injuries in the spine where you would feel them in your bodies. I used to work for a spine doctor and we would have a dermatome map for when I was first learning about it. The dermatome map would be like very interesting to look at for where you feel that in a specific body. Cause it's like, it maps out for, like, place, like, for like where L1, where you feel those in a specific body, and L2 and all that. That would be a great, tool map to look at.
Yeah, absolutely.
Is that all interested?
Yeah, I'll have to look that up. I've never heard that term
It's
before.
a dermatome map.
Awesome. So when we move on from an X-ray, maybe the X-ray doesn't tell us what we need, right? Maybe we don't see any structural damage of the bone, okay? Then we can move to like a CT, MRI. What do we know that a CT can look at a little bit better? Soft tissue. MRI will also show us a lot about the bones and the ligaments and stuff like that surrounding it, but CT can show us a lot with the soft tissue, which would be really nice if we're looking at potentially having a disc injury and that sort of thing. Now an X-ray could show us, let's say we have a disc injury where maybe it's bulging to one side. Then what do we think we would see on that X-ray? We'd see a little bit lopsided, right? Because if it's bulging to the right, then those vertebrae are gonna start to close in on the left side where it's thinner, okay? So it can show us a little bit, but it's not giving us a perfect view. So that's why you might see us kind of upgrade to CT, MRI, and that sort of thing. We can also do a couple of special tests you don't really need to know about, just know that there are some other more specific things that we can do, okay? So, let's say we have diagnosed our patient with a disc injury. We've put them through the ringer with physical therapy. We've tried NSAIDs. We've tried all the things to just kind of calm the body down, proper body mechanics, give it rest, that immobility we were talking about. It didn't work, okay? Or maybe we have a patient that had a herniated disc, which, what do we think that a herniated disc would mean?
It's not in the lineup, it's like out.
Not only is it not in the lineup, what has it done? kind of an enclosed capsule, right? So if it, but it does what?
It's like squished out.
It bursts. So it's not only, I think you said protruding back there, so there is kind of protruding, that's more of like our bulging disc. It's kind of getting there, it's got like a little bubble almost. Herniation means that it has burst open, okay? It is no longer holding the contents of the disc inside it. So that is obviously a step up. It's no longer gonna go back where it needed to be without some sort of intervention. So with that, if we've done all of these other things and it didn't work, maybe we need to move to surgery. So we have a few different surgery options, and we won't really get into the depths of like why we would choose this one over the other one, because a lot of that is gonna be totally dependent on surgeon preference, the patient, what they're presenting like, and what their daily life looks like, right? So we can first do a discectomy. What do we know that ectomy means? Removal. So self-explanatory, right? They take the disc out. But can they just take it out? Or do they have to also do something else to, after they remove it? Yeah, they may do a spacer, they may do some injections in there. Spacer is kind of just like an artificial disc. Sometimes they have different types of spacers y'all don't need to know about. And then maybe we go to a laminectomy. If we take it back to that anatomy, we know that we have the spinous process and then the lamina. So this is just removing part of the vertebra to kind of create some space for that disc, okay? So you're not taking everything out, but you're just creating a little more room for it to roam. Then we move all the way to a spinal fusion. Self-explanatory, if y'all could think about what that maybe mean. Yeah, but what are they putting together? Not always
The
necessarily.
two vertebrae.
Yeah, the two vertebrae, because what does that provide those discs that are involved? Stability. So then if they aren't using the proper body mechanics, or maybe they're just doing the repetitive heavy load lifting or whatever it may be, that fusion just provides that extra support on the sides to where it doesn't have the ability to start bulging or herniating again. And then we can also do the artificial disc replacement, which kind of goes along with the spacers. Okay? Any questions here? If you had to think with the spinal fusion, what would be a difficult part of that?
Movement, range of motion.
Absolutely, especially depending on how many they may have had to fuse, right? Maybe some people just have one disc injury, so they just need to fuse two to kind of create that stability. But I've seen people that have had multiple, and so they're fusing 5, 6 vertebrae, and then, you know, they lose the ability to bend over, they lose the ability to turn like this. So there's a lot of, you know, you kind of have to decide risk versus benefit of like, is it gonna help all of that pain that I'm experiencing, but also how much is it gonna modify my life, which is why you see so many differences between what surgeons choose depending on the patient. So when we have a patient that has had surgery, post-op care, what are gonna be some of the most important things for y'all to be worried about? Or for y'all to do? Absolutely. Where are you gonna focus your head to toe assessment though? Because like, do I really care what their scalp looks like and what their ears look like? No. So then I would say yes, head to toe, because I wanna know from start to finish kind of what you like. I gotta know a baseline. But what am I really gonna be focusing on?
Pain.
Pain is a big one. Movement. The what?
The effective.
Yes, which could be a lot, right, depending on where the surgery is. What about like doing a neurovascular assessment?
Yeah, because it can actually go the opposite way.
Absolutely. They can screw it up just as, well, actually, they can screw it up easier than they can fix it, I'll put it that way, right? So neurovascular assessments are gonna be really important here. But when we also think about that, let's say we have the unique opportunity to have this patient pre-op too. Let's say that this was a scheduled surgery. What would be really important that was documented clearly prior to the surgery?
The same thing.
An assessment, because what am I gonna be able to compare it to when they have that surgery? I need to know, is it improving, is it getting worse? I wanna have a baseline if possible, right? So, if they had some numbness and tingling, and they obviously had pain, and then they go to surgery, and I get them, and it's, you know, that first like 12, 24 hours post-op. Am I expecting all of that to be totally gone?
Absolutely not.
No. Am I expecting, hopefully, for some of that to be improved? Yes. Typically, this is typically, some of that numbness and tingling, you'll see your most improvement with it. Now pain, you're probably not gonna see a lot of improvement with that, because not only Have they been hurting for an extended period of time because of the injury? Now we just went and sliced the back up and screwed around with all this stuff, right? So now they're hurting from that. So pain may not be exponentially better than it was prior to surgery, but hopefully some of those symptoms that they were feeling, especially like in their fingers, toes, whatever it may be, they'll start to feel a little bit different or a change in it. And then as time passes, you'll start to see the progression of that getting better. When we focus on a neurovascular assessment, what are the components of that that you want to be able to focus on, or that you want to be able to do? What do you check for a neurovascular assessment?
I mean, you can do PERLAs, you can do
Okay.
deep pain.
Okay. What else?
Sensation.
Absolutely, sensation is a huge one. What about pulses?
Mhm.
Yeah, I want to know if you get blood flow, right?
Right.
Neurovascular, there's a vascular component there. What about the temperature of the, like maybe it's their arm or leg, right? I wanna know if it's cool, if it's warm, all of those different things, right? What about cap refill? Yes, you should do a cap refill on everybody anytime you got a chance, right? It can tell you a lot, okay? It's a cap refill, pain, what about edema? What could edema tell me? Something's wrong with the heart. Potentially, or what else? It could tell you something as simple as put it up, lift it, right? All of it, you've just slowed down the circulatory system. Our body is saying, hey, there's an injury here, and we're gonna go try and help it out. That's what inflammation essentially is, when it's more of an immune response, right? It's our body saying, ooh, raising the red flag, I've gotta go over here and help this out to fix it, right? I'm protecting it by inflaming it, essentially. What about reflexes? Yeah, I wanna know if they got them, for sure. If they don't, we're in trouble, right? And then the numbness, the tingling, the paresthesia, and also their strength, right? What happens if I go in there and they're extremely weak? Am I like freaked out from the get-go, post-op?
Depends.
What's it depend on?
It depends on where they want to start with.
Absolutely, and also what they have done, like are they still loopy from surgery, or are they still just a little like, oh? Like have we doped you up on pain meds to where maybe I need to give you a little bit more time to get that grip strength back up, or you know, whatever it may be. So we always have to compare both sides too. Why do we compare, or how do you check grip strength? Are you doing one hand at a time?
No, you
Both
should
hands at a time. Doing both at the same time, same with pulses, you should never be checking one pulse at a time, alright? Check them both at the same time, that's the only way you're actually gonna be able to accurately compare the strength of their pulse between one side to the other, right? Cause I'm gonna tell you, I could be 10-second Tom sometimes. If I check the pulse on this side, by the time I walk over to the other side of the bed, I probably forgot what that one felt like, right? And I consider myself to have a relatively good memory in a clinical setting. But I'm gonna be like, well, I think it was about the same. But then if I feel them at the same time, I'm like, oh no, there was some difference there, okay? So then, what about wound care management on a post-op patient for a dressing? What's the number one rule about a surgical dressing? That first one.
Surgeon.
Don't touch it, don't check it, right? If there's bleeding on it. Are we super alarmed if there's a little bleeding on that first initial dressing? No. Are we alarmed if there's a lot? Absolutely. Okay. What's the best way for us to track that?
You can measure it.
Yeah, mark it. Just mark it, put the time by it, right? And then I can go back in and check it an hour later, whatever later, however frequent your assessments are, or however concerned you are, and see if it's changed, right? If it gets saturated, what am I gonna do?
Add to it and then call.
You're gonna what?
Add to it and call.
Yes, you're gonna reinforce and then call somebody that makes a lot more money than us, right? Let them know, okay? But also, what is included in that spinal anatomy that we would really, really, really like to protect? Yes, what's inside our spinal cord?
Spinal fluid.
Yes, what do we think that spinal fluid looks like if we were to drain it out of something?
It's
Do you have
supposed
a
to be
guess?
clear.
Yeah, so, yeah, it should be clear.
Should be.
Okay, but there should also be some glucose in it too. So if I have a dressing that I have a little bit of blood on, but then I also see like a ring of like some clear, sometimes it comes across a little yellowy when it soaks through a gauze. If I see a little bit of clear yellow drainage, what should I
You
think?
should probably be alarmed.
I should probably let somebody know, right? I'm gonna do all the things that I know to do, like get vitals, I'm gonna reinforce, do all of that. But what do I think may have just happened?
And, spinal fluid system.
Yeah, they could have a CSF leakage, which sometimes, minor problem. We just monitor it, it seals up on its own, we're good to go. They have a headache for a week or two, and then it gets better, okay? Major, they go back to surgery. So, but that's not up to us, right? Up to us is just to identify that something has happened that shouldn't be happening, okay? Pain control is obviously gonna be big. Most of the time you'll see these patients on a PCA pump, which we know PCA stands for patient-controlled analgesia. You could have any number of medications on there. You could have hydromorphone, which is your Dilaudid, fentanyl, morphine, all sorts of different things. That's gonna be total surgeon and patient preference and what works best for them. But then on top of that, they're probably also gonna have some PO meds, right? Why do we think that that may be? What does the combination of the PO meds and the PCA pump do?
It covers, keep it covered.
It does, except, I mean, on our PCA pump, we have boluses and we have basal rates, so they're constantly getting a basal rate, and then they bolus themselves on top of that. So technically, even if I just had a PCA pump, they'd be covered all the time, right, in theory? Yeah, but what do we know about IV meds? Do they wear off quickly?
They're short acting,
Absolutely. What has a longer half-life?
PM.
So why do we use the PCA pump on top of PO meds? If the PO meds last longer, is what works quicker?
The IVs.
The IV med. It has a quicker onset, we can treat those breakthrough pains, but then, and it has we absorb it a lot differently, and so it has a greater effect in actually taking the pain down. But then that PO medicine is what's actually gonna keep us at a lower level, so then hopefully we can wean off that PCA pump and start requiring less. You're not gonna get these patients 100% pain-free. We want them to what we call a functional pain, okay? That means at what point could you do your daily activities while still feeling some discomfort? That's our goal, not pain-free, that's just not gonna happen, okay? And then positioning is a big one. With positioning, what do you think is probably the safest position for these patients? Probably, yeah. And if I'm needing to move them, how am I gonna move them?
Multiple people.
Multiple people and do what with them? Roll them, log roll them. I worked at a level 1 trauma hospital in Savannah, Georgia for a while. And I worked in neuro ICU, neurosurgery recovery, and trauma ICU. And we had a rule, we had a protocol. If you had to move a neurosurgery patient, you had to have a minimum of 3 people in the room. You had to have one person that was doing stuff with the pillows, one person that was holding the patient, and one person that was actually doing the rolling. It didn't matter if it was for 2 seconds just to look at somebody's butt, or if it was to actually reposition them, change linens or anything. You had to have a minimum of 3 people, and you could get written up if you didn't do it. It's extremely important because what does log rolling do to our spine?
Maintains.
Yeah, it maintains alignment. And if we think about it, right, if, let's say we have to put a brace on them, would I do that with them standing or sitting? Or with them laying down? If I lay down, what's that do to my spine? Does it stress it? Does it put a lot of weight on it? Or does it take that off? It takes it off, right? If I lay down, I'm in the most neutral position for my spine. I've taken the stress off my spine. It's not working to keep me up. The muscles relax, okay? So oftentimes you have specific orders to only apply the brace while they're lying down. You log roll them to get it back and forth and put it on. Because then as soon as I stand up, what happens to my spine? I have compressive loads, right? Gravity takes effect. Everything starts scooting down. Even if I'm in great physical shape, gravity's gonna take effect. So if I wait until I'm standing up to put on a back brace, is it holding it where I want it to be? No, because it's just encouraging more of that compressive load to be on my discs, which I'm trying to avoid right here, right? Okay. We kind of already talked about the CSF leakage. The big cardinal symptom of that is that they start describing a severe headache, even before I've maybe noticed some of the drainage on that dressing. And where, headaches happen, right? We're talking about an uncharacteristic headache that I medicate you and you're not getting any sort of relief, right? Also, if I know that you've just had spinal surgery and you start complaining of a headache, I'm probably not gonna immediately be like, oh, it's just a headache from being under these fluorescent lights, right? I'm gonna already be considering maybe there's a problem here. So I'm gonna medicate while I'm checking that dressing to see if I see anything on the outside of the body yet, and then see if I get any relief from the medication. If it's not relieved, then it's most likely 100% CSF leakage. And like I said, sometimes we just watch those, and then sometimes we actually do treat them back in surgery. Another thing is urinary issues. Why do we think that retention could be a problem?
Neurological.
Neurological, sure. What else?
Don't know.
What do we know that we have a hard time waking up sometimes after surgery? Your bowel and bladder, right? Sometimes you start dealing with some retention because you've been under anesthesia. Sometimes these surgeries can go for hours and hours and hours, right? Some are quick, but some are extremely long. So we can also have this thing called Cauda-Equina syndrome. Has anybody ever heard of that? Okay, so what can happen here is the lumbar nerve roots get compressed, and what those actually cause is a decreased sensation. Those nerve roots control your bladder and bowel. So then you would have issues with retention with both your bladder and bowel. I have seen a couple of people that they'll have retention for an extended period of time due to the Cauda-Equina, but then eventually they start dealing with some incontinence after they resolve some of that.
What did you say it was again?
Cauda-Equina, right here.
What is it?
Oh, that's where the lumbar nerve roots become compressed and it decreases sensation, and those nerve roots are attached to, like, they control your bladder and bowel. And then GI function, kind of the same thing. So paralytic ileus, y'all have learned about that with elimination, small bowel obstruction. So we would wanna make sure that we're monitoring them for that. Most of these patients pre-op, if we can, if we know that this surgery's coming, a lot of times surgeons will go ahead and pre-medicate them with like a stool softener or Miralax like a couple of days in advance so we can make sure that things are moving. Cause would we want these people to be bearing down? Absolutely not. And also, if you think about it, if a patient has some severe constipation, where might they feel some discomfort? In their back, absolutely. It's gonna start building up somewhere, right? We just look at anatomy, you're probably gonna feel some of that pressure in your back. Do we want to increase that pressure? No. Okay. All right, any questions about disc injuries, that sort of thing? Okay, so scoliosis. This is one that most people are relatively familiar with. It gets talked about quite a bit. For the most part, we don't really know why a lot of people have scoliosis. Just draw the short stick or the short straw and just ended up with scoliosis, okay? But then there's also some congenital and neuromuscular issues that we could have, which are typically accompanied with other conditions like cerebral palsy, muscular dystrophy, things of that nature. And then we can also have some that are caused by actual trauma. So let's say someone has a severe injury due to a car accident or whatever it may be, and it then causes them to develop scoliosis a little bit later in life. That can also happen. Most of the cases are gonna be your idiopathic, which just means we just don't really know why you got it, you just do. And we start to see that developing most of the time in like late teens, adolescence, and that sort of thing. If you attended public school, especially, I know for a fact in the state of Alabama, anytime in the last probably 40, 50 years, then you probably went through scoliosis training, okay? They start it in elementary school and they don't really tell you what's happening, but they like walk you through and you go in the office and they have little like slots set up and you stand there and you just bend over and they run their finger down your spine and they're like, okay, you're good. Or they send a letter home to your parents, okay? That's all they're doing is they're checking for scoliosis. They're doing what's called an Adam forward bend test. And they're seeing if they can actually see the curvature in your spine, which a lot of times we can in kids, because they don't have quite as much tissue, like soft tissue, muscle, adipose tissue and all that kind of covering their actual spine. And then they're also looking at their hip height to see if one hip is higher than the other, and they're also looking at their shoulder blade to see if when they bend over, if one shoulder blade sticks up more than the other. That can tell us they have a curvature as well. That's what we're looking at here. This one isn't super, super obvious, but you see that one shoulder is a little bit lower. This is kind of in the process of an Adam forward bend test, but typically they have you bend all the way over at the waist to be able to see, okay? This is more common in females. What else did I tell you here? Growth spurts, that's a good one. So a lot of times growth spurts, you may see help benefit this because they're stretching out, they're kind of getting some more room for things to straighten. But then you also may actually see it exacerbate scoliosis during those growth spurts. Sometimes that'll happen in patients that grow at a really fast rate. So if you think about it, sometimes if someone grows really fast, their bones are growing, right? Those things are stretching, but then what probably isn't catching up quite as quick? Muscles, tendons, ligaments. So then if those are all really tight and pulling, then what could it do to the spine? Hold it in a position that it doesn't need to be in, right? So we can see some exacerbation of scoliosis during growth spurts as well. So to diagnose it, we already talked about the Adam forward bend and that sort of thing, but then this is an x-ray of an actual scoliosis patient. And then what they do is they measure the Cobb angle, which is just a name for the degree of curvature. It's just the person that decided to talk about it a lot, and they named it after him. And then they may, if it's severe enough, go through doing like an MRI and that sort of thing to see if there's something else that's causing it that they may also need to treat as well. As far as classification goes, I don't necessarily want you to like focus on memorizing like, oh, mild is 20% or less, but understand that if it's less than about 20 degrees, then we're not really concerned, right? And then when we get a little bit higher at that mild, typically we're just watching you. We're just making sure that's not causing any problems for you. Moderate, we'll probably start bracing, and then kind of your next number that I would say to be familiar with would be the severe, so greater than 50 degrees. Then that's when we would look at probably doing some sort of surgical intervention. Okay. So when we look at bracing for those moderate patients, then we're thinking that we would do we have a couple of different braces that we could try. And really this is just gonna be determined by where the curvature is and how we need to straighten it. But just know that there's a few different ones that we could choose from. And then all of the same rules typically apply for the bracing of scoliosis that we talked about, like with positioning and that sort of thing, and getting the brace on and that sort of stuff when we're looking at bracing for scoliosis versus the surgery. Something else to consider is body image, right? If we're thinking adolescents, teenagers, that sort of thing, if you could imagine some of these braces are pretty bulky, okay? So if I'm putting a 16-year-old that's got prom coming up, that has learning how to date, that has all of these different things, right? And then I put them in this big bulky brace that everybody's gonna be able to see. There's probably gonna be a psychological component to that, right? There's also gonna be the potential that they might not wanna be super compliant with it because, well, I don't wanna stick out. Like I wanna wear the fancy dress to prom without having the brace on. I wanna, play baseball. I wanna do whatever it is. And so making sure that we're doing a lot of education there, why you have to wear it. Because typically they're wearing this like 23 hours a day, okay? Now it's not a hard rule, but a lot of times they are, about 23 hours a day. They can take it off to shower. Sometimes they'll let them take it off to sleep depending on the doctor and the curvature, but oftentimes they're wearing it for the majority of the day, okay? And it goes on top of the clothes, so you can't really hide it. Then when we get to the surgical correction, we kind of go back to that spinal fusion, which we already talked a good bit about. The difference being here, sometimes it may be a small portion of the spine, but sometimes with these scoliosis spinal fusions, it can be almost the length of the entire spine, depending on how bad the curvature is, okay? Again, your post-op scoliosis care here is not gonna differ greatly from our post-op disc surgeries. We're just gonna make sure that we're doing those frequent neurovascular assessments or neurological assessments, making sure that we are seeing some improvement there. Doing all of our same assessment of our wound care, things of that nature, mobility. They're typically gonna be relatively limited, especially in like lifting and that sort of thing, for about 6 to 8 months. It's a rough kind of average. Some will be a little bit shorter, some will be a little bit longer. And some of that will also just depend on how they're recovering as time passes as well. No bending or twisting, which honestly, most of them after surgery can't anyways, because now we've put these large rods in your spine that kind of eliminate your ability to do that. But making sure that they know not to try. Don't test your limits, right? Now's not the time, okay? And then the psychosocial support that we kind of talked about, making sure they're understanding what's going on and why it's important to care for it and to do things the way they're supposed to. Finding them support groups could be really helpful too, especially with people in similar ages, similar situations. You know, I consider myself to be pretty empathetic, but I've never had a scoliosis surgery. I've never had to wear that brace, right? So I can't truly understand how you feel. And so being able to like link them up with people that actually can relate can make all the difference. What else? Obviously monitoring for signs of infection. What might a surgical, like a localized surgical infection look like?
Redness.
Yep, redness, absolutely. Swelling, drainage, for sure. Okay, what about once it's more systemic?
Fever.
Fever. Remember, a fever is not a sign of a local infection. That's a sign of a systemic infection, right? Like if you get a scrape on your finger and it gets a little infected, you don't spike fever, do you? No. Right? Now, if that were to then get MRSA and that were to spread to your blood and all things, then you probably spike fever. But, so, sometimes people get that a little bit confused with trying to correlate the fever with infection. Not always, because sometimes we can have a little local infections, and hopefully we catch it before it becomes systemic, right? Okay. All right, any questions about scoliosis and discs? No? I'm rolling through pretty quick. Okay, fractures. Everybody, for the most part, has been around some sort of fracture. If you grew up at my house, you were around them a lot. I grew up on a farm with brothers, so we broke a lot of bones. But if you look here, this just kind of gives you a lot of the different types of fractures. You don't have to know every single one of them. Please don't do that. Don't spend your time doing that, okay? Just know there's multiple different ways that we can do it. When we think about what causes fractures, it seems kind of self-explanatory. What do we know are some causes? Yes, but what necessarily does trauma mean? Falls, car accidents, all of those things, okay? And then what other, is there any other way that we could potentially break a bone? What'd you say?
Deficiency.
Okay, so that would fall kind of more under the umbrella of maybe pathological. I think I heard disease processes, okay? What other disease processes were you thinking? Okay, yeah, osteoporosis, which we know decreases the bone density. We have, what about cancer? It does, but then also we could potentially have tumors too that grow. And let's say that tumor grows and grows and grows and grows and grows, it could potentially actually break the bone because of the pressure that it's exerting on it too. So that falls under the pathological. So you think trauma, it's done to me. Maybe I was the one that made the stupid decision to do it, but still it was done to me, right? And then pathological, my body has done it to itself. We have open fractures, which we know break through the skin. I don't know if anybody ever watched that TV show Scarred, so you're not probably too young, on MTV. We didn't have cable, but that was like the one show that I would always wanna watch when I was over at my friend's houses, cause I don't know why. But, they all got better, they were fun. But I enjoyed seeing all the different broken bones. And most of them were open fractures. And then we have closed fractures where the skin integrity is maintained, nothing pops through. But that doesn't necessarily mean that it's not or that it's any less severe than an open fracture, right? But we do realize that an open fracture puts us at a greater risk for what? Infection, right? We've just given it a direct route for germs to get from the outside in, right? Okay. And then we have the classifications there about a clean break. Comminuted just means that there's a lot of fragments that go along with it. Spiral is twisting. What do we think that spiral could often be associated with?
An ankle.
Abuse. Yeah. Could ankle, yeah. If it gets caught in something, you see them in car wrecks sometimes where they get caught, they hit head on. But why abuse?
Because like people grab hold of their arms.
Grab a hold of their arms. So let's say I'm working in an emergency department and I have a kid or an elderly person, or really of any age, right? that comes in with a spiral fracture, am I immediately gonna be like sounding the alarm? No. Do I keep the thought in my head of like, oh, I need to investigate this a little bit further, make sure that the story makes sense? Absolutely. Cause I'll tell you, I have 2 little boys and they are wild. And I've had to snatch them from jumping off a ledge before, right? And I'm just grabbing whatever I can grab to keep them from launching themselves into the oblivion, right? And when I say they're wild, I really do mean that they are wild. So, you know, I could see where there's a potential that, you know, it could happen, right? But should obviously make us think a little bit further through whatever the story may be. And then green stick is an incomplete break. This is typically what people refer to as like a fracture, right? Technically fractures are all of them, doesn't matter if it's blown to smithereens or if it's just like a hairline fracture that they call it. But green stick is typically, that's what this top right one is right here. That's what is most common in children. A lot of that is because kids' bones are still kind of malleable. They're still a little bit flexible. Okay, they can move a little bit, bend, they can take a little bit of stress. So, what are these patients gonna look like if they do have a fracture? What are you gonna find on your assessment?
Guarding.
You could. Swelling is probably, you know, it's not gonna be like the very first thing, but it does happen quickly. What'd you say?
Guarding.
Yeah, guarding because they're what? They're hurting. And maybe not initially, right? Like I said, I've broken a lot of bones. Sometimes I've broken them and I'm like, yeah, you know, like, it's broken. But why am I not hurting right then? Adrenaline, right? That adrenaline's gonna wear off at some point, okay? So initially, maybe I'm not super painful, but eventually that adrenaline's gonna wear off and then I'm gonna realize my arm is in a shape that it's not supposed to be, right? And then the deformity, we're looking at the misalignment, that's true for if it's open or closed. And then we also have, you know, or what would we do to diagnose it? X-ray, right? If we're concerned about there being soft tissue involvement, then we could advance into like a CT, that sort of thing, to make sure that there's not something else that we need to look at, like tendons and ligaments, to fix those as well. But typically X-ray is about as far as we go, okay? So, if you were to, outside the hospital, or even inside the hospital, something crazy happened, right? If you witness someone break a bone, that sort of thing, really all I want you to know is don't try and straighten it out. Don't be the hero, okay? Just splint it as it lies. We don't wanna try and fix it. We don't get paid enough for that. We're gonna just splint it as it lies, help protect it, keep them as comfortable as possible, and get them to somebody else that can actually do the diagnostics to be able to fix it. We're also gonna make sure that we're doing neurovascular assessments. So we wanna make sure that is it getting blood flow? Are they getting sensation? That sort of thing. Because then also, when I do splint it, I wanna make sure that I'm not the one that caused them to not get blood flow, right? So, there's some liability there,
It
right?
happens.
We don't wanna be the person that cuts off the other blood supply to the foot. And then obviously get them to somebody else, right? So, we can fix it a couple of different ways. So if it's a closed fracture, meaning it hasn't popped through the skin, we can do a closed reduction. This is typically what is most commonly done, okay? This is, we're gonna give you a little happy juice, we're gonna give you like some Versed, something like that, to just make it a little loopy, so you don't remember what's going on, you don't feel any of the pain, it knocks out your pain receptors, but doesn't totally knock you out. And then the doctor's gonna look at the X-ray, or the CT, whatever, and see kind of where things are misaligned, and then they're gonna pop it right back where it's supposed to be, okay? It's quick, simple, it takes like 5 seconds, ideally, and then you have yourself a good little nap, and then you wake up, right, and you've got a cast on, okay? Then, when we do that cast, if it's a plaster cast, which now we have a lot more options, so a plaster cast, we know that it has to stay dry, right, because what happens to plaster if it gets wet? It gets soft, and it does what? It heats up too, right? So if we get it wet, and then also if it's an enclosed space, so we can't cover them all up. If you have wet plaster and even sometimes dry plaster, then you cover it like with a plastic bag or something like that. If it's not all the way dry, it generates heat and you get chemical burns inside that cast without realizing it. So there's also a lot of barriers between the actual plaster and the patient's arm, okay? When you're handling that, especially right after they've had it, you wanna make sure that you're doing like open palm, right? I'm not gonna like go grab their arm and pick it up like this, because what is it if I pick it up like this and it's still not dry? What am I gonna do to it? Yeah, I'm gonna compress it, I'm gonna put pressure on different points on the arm, I'm gonna move that cast a little bit, I'm gonna misshape it from how they wanted it. So you wanna make sure your open palm kind of underneath it to keep that natural curvature that they created. And then we can also do, now they have like water resistant cast, they have the air cast now that look like a brace, but it fits. Most of the ones I've seen have been arms, and it fits over the arm and it blow air into it, and it's like a netting, so your skin can still get some air. You don't have all of that like skin sloughing and everything that happens in a like more traditional cast. So I have a few more options nowadays. I don't know if I would trust a water resistant cast, but some people probably will. Cause if you've ever smelled a cast that has gotten wet, that's a stank that you just never get rid of, I don't think, so. And then we can do traction. Has anybody ever seen a patient in traction, or?
Is that like those halos for scoliosis?
It's a type of traction, yeah, absolutely. So a halo is a type of traction. Well, kinda, we can do halos for support, and then we can do halo traction. You talking about little kids on TikTok that have the
Yeah.
halo and they're on the little thing they're spinning around? Yeah. Yeah, that's halo traction. The first time I ever saw that in person, I was
scared.
weirded out. I was like, what in the world? But it looks like a fun ride, I guess. While they're spinning around, just like rolling around, has everybody seen what I'm talking about? Okay, so you know what a halo is? Okay, so they have the halo, and then they have like a back walker, so it's a walker that like the part is behind them like a cage, and then it has an arm that goes up above them, and it has a cable system that attaches to the halo, and it holds their body weight. Now sometimes like it holds a certain number of pounds to like take some of that stress off of their spine, but then other times like they have it set to where they could totally lift their feet off the ground and it'll hold them. And those little kids be ripping and running around the unit sometimes with those things, and they'll just like raise their feet off the ground and spin around, and it's crazy looking. But, cause I mean, they don't feel the pain, it actually feels nice to them, cause it's taking the stress off of, and your skull is pretty darn strong. It can hold some things in there and they just screw the bolt straight into your skull, so. But it's trippy to see it the first time in real life. But yes, that is a type of traction. Yeah.
Yeah, it's so creepy.
Yeah. And they'll like, I've had them like race. Like they'll be in the hall and they'll race each other and they like run for a second and then they lift their feet off the ground and see who can go further.
We're kidding here.
Yeah.
That's.
But you know what? If that's what gets them through the day,
I mean,
you
I would
know,
probably be okay with it,
I can-
like after I was
you
there.
you get used to it.
I had to be there for a minute.
Yeah. But you do start to get like, but you know, it's kind of similar to the circus act with like the hair.
Mm-hmm.
That seems way worse.
Or like in the back of their.
Like at least they've got bolts. Like, you know, they got some hardware. I got a lot of hair and I can't imagine like
You
being
feel like you're going.
swung around on a trapeze by just, I don't know. But that's off topic. Anyways. So, but then other traction that we can use, we have two types, which we'll get to in just a second. We have skin and skeletal. So skin is more so related to like having a brace, on the outside of the body, and then we connect the traction to that, and then skeletal, we're actually putting something into the bones to be able to pull the traction that way, and we'll get to that. We already pretty much talked about all of this. If they do have a cast on, we wanna make sure that we're doing all of those neurovascular checks, right, because I wanna know if they're starting to lose sensation, if their arm is getting a little too swollen, or leg, or whatever it may be, right? Make sure they're elevating it, taking care of it the way that they need to. Make sure they know not to stick anything down it. I don't care how bad it itches, sorry. Don't put anything down there, right? It's always funny, I have a friend that works in peds and they have kids that come in and get their casts off all the time, and like, they'll have like little toy cars and like Play-Doh and all kinds of things down there because it's a cool little hiding place, right? It's just a treasure box when they take them off. So make sure they understand, don't stick anything down there, especially wire hangers. It's like one of the worst things. So, then we get to traction. So if you think about it, sometimes, what do we know that we just said happens really rapidly after you have an injury, like a broken bone? Swelling, okay? So if I have a broken bone and then have a lot of swelling around it, is it a guarantee I'm gonna be able to get it back where it needs to be right then? No. Is it a guarantee that even if I don't have a lot of swelling, I'm gonna be able to get it where I need it to be?
Absolutely.
No. Sometimes bones can be really tricky. So we have this cool thing called traction that we can use. And sometimes we use that to gradually be able to put things back where they need to be. We also use it with scoliosis and stuff like that to really gradually stretch things out to kind of provide a little bit more space prior to surgery and that sort of thing. And so there's two different ways that we can do that. We can do skeletal traction and skin traction. So skin traction, like I said, there's typically a brace or a wrap of some sort that's on the outside of the body, and everything is connected to that, okay? There's nothing going into the leg or into the arm or whatever they're trying to do the traction on. Then you have the cable that goes through a pulley system, and then you have free hanging weights here. That weight is gonna be prescribed by the doctor, how much they need to have on it, okay? They'll typically have a trapeze up above them so they can help reposition themselves and that sort of thing, okay? And then you also have something called opposing traction. In this picture, the patient's body weight is the opposing traction. But, I was gonna say, I thought I had a picture, but maybe I don't. But also opposing traction could be another set of a pulley system that also pulls in the opposite direction. But I would say probably 75–80% of the time, their body weight is the opposing traction, okay? Then we get over to skeletal traction, which is where we've actually inserted rods, pins, screws, whatever, into the bone, and then we're connecting to those on the outside of the body. So they go from the inside out. There's an exterior portion. We're connecting to those to then be able to straighten it, okay? Same concept, has the pulley system with the free hanging weights. Biggest things here is you never want those weights to hit the floor, because if they hit the floor, are they putting as much weight as they're supposed to? No, okay, we want the weights to be free hanging. We don't want anything hanging on any of the cables. We wanna make sure that they're aligned correctly. We wanna make sure that there's the correct amount of resistance and that that line of pull is unobstructed. Like, don't have a bunch of pillows to where, you know, like it's not gonna be able to pull correctly, okay? Obviously, positioning, movement, all of that is uncomfortable and difficult with these patients because I'm sitting here saying I've gotta have the specific, you know, like line of pull. I need it to be straight. Well, then how in the world am I gonna get this patient moved around in the bed and all that sort of stuff, right? And so these patients sometimes don't follow the exact like Q2 hour turn side to side. We do a little bit different positioning and it involves having to kind of realign that traction and that sort of thing. So it's just a little bit trickier of a situation. If you look here, we already kind of talked about the actual traction itself, but then we know that we're obviously gonna be doing neurovascular assessments because if we're stretching stuff out, then we know that we can interrupt that. We wanna make sure that we're having sensation, that we can wiggle our toes, that we have circulation, that you know, we have good cap refill, all of those things. If you understand your 6 Ps of neurovascular assessment, you should be good, okay? Typically those are done every 2 to 4 hours. Sometimes in critical care, we're doing them every 30 minutes to an hour, it just depends. Pin site care, so if you think about it, what do we talk about with open fractures? They're at high risk for what?
Infection.
Because we gave them a direct route, right? We're doing the same exact thing with pins, okay? Now, let's say they have like a lot of crusty stuff around the pin site. Are you gonna leave it?
No.
Yes. Absolutely. What does a scab do?
Close
It's your own body's bandage, right? It's protecting it. If you pick that scab, then you're opening that skin back up, okay? If I get crusty stuff around that pin site, I'm not gonna pick it off, because then I'm just opening a wound, right? I'm gonna leave it. Now, if it's like gross all over the place, I'm gonna clean it up a little bit, but I'm not gonna sit there and pick at it like a scab, right? It's your own body's bandage. It's just like a blister, right? You're not supposed to pop it. It's your body's doing the work for you, okay? And then looking for the signs of that localized infection that we already talked about. And then equipment checks. So Carol P. Smith is just an acronym for all the things that I just went over really. That you want your pull to be continuous, so you don't want to interrupt it. You don't want to take the weights off unless it's prescribed for you to take them off, unless you have an order. You want the alignment to be straight. You want the resistance to be what you need it to be. You don't want it to be, or your opposing traction, so either the body, like their body weight, or prescribed opposing traction, right? And then line of pull, you don't want it to be obstructed. And then the P-Smith just comes from your assessment, so your pulse, sensation, motion, inner space, meaning like fingers, in between fingers and toes, temp, and then hue or color, right? That's all the things that you're gonna be assessing for a neurovascular assessment. So it just puts it in an acronym. Skin assessment is obviously really big because pressure points, when we already kind of talked about repositioning, is just tricky. It just takes a few extra hands to do with these patients. We can also do surgery. We can do an ORIF, or an open reduction with internal fixation, meaning we open the limb up, we fix it with the plates, screws, pins, whatever it's needed, rods, and then we close it back up. Everything's contained, okay? Everything's inside the body. Then we can also do external fixation, where they do make incisions, and then they put pins or whatever it may be, but then those also are exiting the body to where then they typically have some sort of fixator on the outside, or sometimes people call it a cage that keeps everything where they need it to be. I've also had some physicians that they will occasionally like go and adjust that external fixator to kind of put it in a different position if they need to kind of gradually adjust something. But you can also imagine that that's probably not very comfortable to hang out with, right? To just have on your leg all the time for, 2 months, 12 weeks, depending on what you broke and how bad you broke it. One of the good things about the external fixator is, let's say that, this one's an ankle, so we'll use an ankle. So let's say it's your ankle. Well, what do we know is also a really large tendon in your ankle? Your Achilles. Okay, so let's say we hurt our ankle, but we also tore our Achilles, and we need help with the Achilles, but also the bone. What this does is they can fix the bone, let some of that swelling go down, let your tendon go down, because typically if we're tearing a tendon or a ligament like an ACL, MCL, Achilles, anything like that, they're not immediately doing surgery, right? They're letting that immune response calm down a little bit, the inflammation go down a little bit before they then go and operate. You gotta have a little bit of room, let everything stretch out a little bit more. What this does is it allows room for them to then go in and fix that without a big bulky cast or anything like that. So they can go in and fix that Achilles or whatever it may be, knee, whatever. So they have access still. We'll get through complications of fractures and we'll take a break, okay? So, obvious complications would be the bones just don't go back the way that they were supposed to, right? The puzzle piece doesn't fit, okay? Then we can also have neurovascular issues, meaning that damage has been caused. Maybe it was a nerve issue, maybe it was muscle, tendons, ligaments, whatever it may be. Sometimes that, if it's not treated correctly, it can lead to permanent issues. Infection is obvious. Blood clots, why would they be at a higher risk for blood clots?
They're not moving.
Yeah, they're not moving, right? And also, what do I have on their leg? Potentially, if they broke their leg. A cast, right? And are they moving that muscle much? I mean, even if I'm in the bed, I can kind of move around and like flex my feet, my ankle, and do all the things. Are they moving? We have totally immobilized whatever limb, right? So they're at a much higher risk for clots. And then we have compartment syndrome. So has anybody ever heard of compartment syndrome? Yes? It's a nasty looking thing when we have to treat it with a fasciotomy. But essentially, let me just see. So compartment syndrome is where either the fascia, which is what holds the components in, okay, so that is the external part of the compartment, either that becomes too large and it closes in on what's inside the compartment, or the components inside the compartment get too large and they start pushing out, okay? Either way, it's not fitting the way it's supposed to, right? The pressure becomes too great. The pressure that becomes too great on that fascia, which holds everything in, and then if we know that that's happening and all of that pressure is built up, then what do we think might happen with circulation? Yeah, that pressure is gonna increase, and then our blood flow is gonna decrease, and then what happens to tissue when we take away blood flow? It dies. I mean, there's not really a nice way to put it, right? It becomes hypoxic and it dies. Do we want that to happen? Absolutely not. So what do we think is the best way to fix it? Are you gonna elevate their leg?
Cut it.
Yes. Are you gonna elevate their leg though? No, why would we not wanna do that?
Actually causing more pressure.
Well, and two, why? If blood, when blood sits, what does it do?
Coagulates.
it clots, right? So if blood sits and I'm not circulating correctly and I've just got blood sitting down there, and then I elevate my leg up above my heart, and then it does make its way back down, what am I probably gonna do? I'm gonna throw a clot down, right? We don't wanna do that. We would like to stay alive, right? That's the goal here, okay? So we don't wanna raise it up, and then am I gonna put ice on it? No, why? What does ice do? It causes vasoconstriction, it's decreasing blood flow. Now, that doesn't mean go throw a heating pad on it, okay? I'm just saying don't put ice on it, okay? And then, if it's severe enough, what are we gonna do? We're gonna
Cut it.
slice it open. If you've ever seen a fasciotomy done, I don't think I have, yeah, I did have a picture in here. It's a very, I don't know, if you like gory stuff, it's awesome to see. I've had a patient at the bedside that we had to do one, we did make it to the OR, and we did one that was all the way down both legs, from butt to heel. And it was, I mean, it was terrible for her, but it was awesome, okay? So, and also none of us were expecting it, the surgeon just went and was like, whoosh, whoosh. So, could be a little exciting, yes.
So I know a girl who unfortunately has this, but she's had about, I wanna say she just had her 15th surgery, because it came back 3 times. So we'll make it keep coming back.
But the pressure keeps building up. Does she have like exercise-induced compartment syndrome? Cause that's the thing.
So some geneticists are studying her, seeing what's causing it, so she doesn't know yet.
Oh, nice.
So she just keeps getting it.
Yeah, you can have like intermittent compartment syndrome. I have a friend that had exercise-induced compartment syndrome. And so basically, like every time she would run or whatever, like ride the bike, anything, she would get compartment syndrome. She'd get really bad cramps in her calves, and it wasn't because of dehydration or anything like that. And they can do pressure studies. They basically put her on a treadmill, made her run. They studied the pressure in her calves. And then what they do is they made like little tiny incisions in the fascia. So they made little incisions on the outside and then a couple, and hers went away, but also it was enough room for her to, you know, it didn't cause any problems. But I would imagine if the fascia starts to regenerate or starts to close back up, then she would have problems again. So maybe it's something like that. But also since geneticists are involved, it's probably not that at all. It's probably not that simple. It's probably way more complicated than I've ever thought of. Yeah, it's not fun. It's very painful. And what do we assume that they're probably gonna feel like? Pain extremely out of proportion. They're like, ow, this is extremely painful. Nothing's taking the edge off. We start to see some of that decreased sensation. It's pale. A very late sign would be that we lose a pulse, which hopefully we've raised a red flag before we lose a pulse.
Probably freak
Right.
out if they see it too.
Do what?
They probably freak out if they see it.
Some, but you know, like the one that I had, like she was intubated, like she was sedated. We had paralyzed her and sedated her, so she didn't have the ability to like communicate with us. It was purely just off of the assessment. And the first thing that we noticed was just that it was a little bit paler than the other. And then the second one happened straight after, so, you know, it can happen quick. And then paralysis is also a late sign, their inability to move it, okay? So this is what a fasciotomy looks like. This is on a calf, okay?
Is it on my legs?
No.
No.
You can have it other places, you're just more likely to experience it in your legs because A, there's more blood flow to your legs, gravity takes effect, that sort of thing. You're less likely to, like let's say I have a cast on my leg, but I'm able to get around on crutches or whatever, there's more blood flow going down and it's got a lot further and it's have a lot more resistance to get back up. Whereas my arm, I'm moving my arms, I'm doing the things, and so it doesn't have quite as much of a journey to go there and get back. So it's just more frequent in the legs. So what they do is they just take a scalpel and they just slice through the skin and then they slice through the fascia. And then, you wanna know the really cool part? They leave it.
Just like that.
Yep. They leave it like this because do you think that that's gonna close? Am I gonna get that to connect to that? I'm not a mathematician, but it doesn't add up, right? That's not going to that right now and probably not anytime soon.
I guess
Okay.
infection might be an issue.
Oh, huge, huge, huge. A lot of times if we give them a fasciotomy, they're immediately on antibiotics, just to cover our bases, right? So, but am I gonna just totally leave it just like this? What do we think that I'm probably gonna be doing? A what?
Wet
Yes, a wet dressing. It's like a loose, moist dressing. I'm not taping stuff to that. I'm not wrapping anything around it. I'm occasionally you'll have a physician that'll want you to wrap like a Curlex or something just to hold it, but I'm talking like you should be able to like move it like this away from their leg. We don't want any extra compression, okay? We don't wanna create essentially a new fascia that's closing in on it, right? So moist loose dressing, and I hate the word moist, I'm with everybody, but what else would you call it, right? And then, eventually, sometimes the swelling goes down to where they can close it. Sometimes it doesn't, so we have to do skin grafts. So they can either do a skin graft from that patient if they have enough skin somewhere they could take from their own body. Sometimes we can do cadaver grafts from a cadaver, take skin from them. You know, if you're an organ donor, your skin's an organ, so that's an option. And then sometimes you actually see that some of the more advanced facilities, they'll actually use tilapia skin because it's actually really close in genetic component to human skin, and so it actually causes our skin to regenerate when they combine it. It's actually really cool if you ever look up studies over it. It looks crazy, but
Like
Um,
fish tilapia?
Yeah.
yeah, farmers tilapia. Yeah, I mean, they descale it.
Okay, that's what's good.
Yeah.
That's the skin.
They don't leave the scales on. They descale it, but, and then they remove like the fatty, like the furthest fatty layer. And then they're able to suture that and like adhere that to the human skin. And it actually helps our skin start to regenerate and grow. Whereas typically for like an allograft or an autograft where we're getting like another human skin, for some, it doesn't regenerate quite the same. It just closes the gap, if that makes sense. You won't always have fish skin, if that makes sense. You won't just be like Aquaman walking around with, with a fish leg. If they don't get all the way to the fasciotomy, if they have a cast on, they'll just bivalve it, which just means that they just crack it open on one side and open it to relieve some of that pressure, okay? This obviously is a medical emergency if we have to go and do a fasciotomy. That's why sometimes we don't make it to the OR to do it. Sometimes they do it at the bedside. Last, thing before break is a fat embolism. So similar to a pulmonary embolism, we can have a fat embolism. This is often associated with fractures and breaks of long bones, most commonly associated like with your femur and hips, okay? What do we know is inside our bones?
Marrow.
Yes. What does bone marrow have in it?
Red blood cells.
Well, we know it has red blood cells and then it has fat too. So let's say we go and we break that in half.
And
Okay.
it just leaks in.
Then it could leak and we could have some of that fat, some of those fat globules actually travel into our circulatory system. And then if they travel and they go to our heart and lungs, then that's not good, right? We don't want them to go there. That's not where it's supposed to be. So, biggest thing these patients will have, or the big cardinal symptom is a petechial rash on their chest and neck, like upper body. They'll feel a lot of the same symptoms as they would with a pulmonary embolus because they're gonna be very short of breath. They're gonna be like, they don't typically associate that impending doom with a fat embolism like they do a PE. You know, PE patients oftentimes will look you dead in your eye and be like, I'm about to die. They know it's coming, right? And if they tell you, if a patient ever tells you, just a good rule of thumb, if they ever tell you they're about to die, just believe them, okay? Please. Don't be the one that's like, no, you're not, because they might, right? Might be a reason that they're saying that. But all your symptoms would be the same. So shortness of breath, tachycardia, really anxious. They might not have that like specific impending doom, but then that petechial rash is the biggest thing. That's a classic indicator of a fat embolus. And then for that, they're gonna take a chest x-ray, potentially CT if they've got time, but that would be a medical emergency as well. You're gonna provide the supportive care, like put them on some supplemental O2, prepare for them to be seen by the physician, and they would most likely require intubation ultimately, and some ventilator support. And that's kind of what this all talks about. They might also put them on some fluids because they're at a higher risk for some hypovolemic shock. But other than that, we've kind of already talked about all this. Any questions so far? Alright, let's take a 10-minute break. So